Hello, everyone. Welcome to Researching Happy. Today, we're diving into a stark and uncomfortable question. Does it make sense for governments to fund both suicide prevention programs and assisted dying? And where exactly is the line at which suffering or the perceived lack of quality of life overrides the inherent value of human life? I'll be upfront with my personal view. I'm concerned that suicide prevention and assisted dying come from incompatible worldviews about the value of human life. We view suicide as a tragedy because every human life has inherent worth and no amount of suffering erases that. The medical profession has long held a similar commitment. Life is valuable and the healer's role is to preserve it and to relieve suffering. For centuries, the Hippocratic tradition of do no harm guided that approach. And the American Medical Association has repeatedly affirmed that the physician-assisted dying is fundamentally incompatible with the physician's role as a healer, difficult to control, and carries serious societal risks. At the same time, many will argue that when suffering becomes unbearable and unrelenting, society should allow individuals to choose death if they no longer see their life as worth living, especially in terminal cases. Others will highlight how humans can discover meaning, purpose, and even growth amid profound hardship, as well-being science and stories from palliative care sometimes show, and we've touched on this in the past with Dr. Xavier Simmons. These questions carry real weight. How do we draw the line between transient suffering, where prevention efforts matter most, and unrelenting cases? What happens to the doctor-patient relationship when if medicine includes ending life as an option? How does government funding death as a solution risk bracket creep, where eligibility expands over time, something that we've seen debated in several countries? And how do we have productive conversations when this is so closely tied to people's cultural and religious beliefs? To help unpack this thoughtfully and with care, I'm thrilled to be joined with Dr. Kristin Collier from the University of Michigan. She's a practicing internist, associate professor of internal medicine, and director of the program on health, spirituality, and religion at the Medical School. She's thought deeply about patient dignity and what it truly means to heal. So, Kristin, welcome.
Thanks, Matt. Thanks for having me on the show for this important conversation.
No problem. So, yeah, could you give us a bit of a summary of your background and maybe any initial thoughts on that little introduction?
Yeah, no, thanks for that introduction. My academic interests really right now intersect deeply with this conversation. Currently, my academic interests really are around one main question. How do people in medicine understand human dignity, human worth, human value, whatever word you want to use for that? And then how do those concepts and thoughts about human dignity root our obligations to patients, especially at the margins of life? So I'm very interested in thinking about topics such as euthanasia, physician-assisted suicide, abortion, and trying to think about how we can continue to advocate for the intrinsic dignity of all human persons so that we can make a better way forward, especially for our patients who over the centuries at the hands of medicine have been victims of ableism and ageism and racism because we don't see all human beings as having inherent worth and inviolable dignity. So how can we move forward with a more just medical system that sees everybody as having value regardless of their ability, disability, station? So that's currently my academic interest, and these topics obviously engage deeply with what we're about to talk about today. Regarding your opening comments, I agree. I do not think that there's any coherent system that at the same time can advocate for suicide prevention. And also, in some other circumstances, suicide is fine and actually good for the patient. And we're going to have medicine participate in that. I do not think that that makes sense. Do we think that suicide is a tragedy or not? Why do all of us, even to this day, if you were to come into my hospital right now and say that you are suicidal, we would say, actually, like, that is not the right course for your life. We would override your autonomy if need be and put you in the hospital against your will. That's how strongly we feel about it, actually, and say this is not in your best interest. That's not a religious argument. You don't hear people say, well, keep your religious thoughts off my body. Like, that's not like a religious argument. We actually like value your life, but we think it's wrong. But in other situations now, in certain jurisdictions, certain countries, I'm supposed to, as a physician committed to do no harm, say, actually, well, in that situation, your suicidal thought actually is valid. It is the right choice for you. And I'm supposed to help you aim at your death, that to me is incoherent. So I'm really excited to unpack this discussion with the seriousness today it deserves.
Yeah, appreciate it. And you, let's just jump straight into it, I guess. But
Mhm.
it's so interesting. I think the word dignity there is like both sides of this argument will be saying, no, we're fighting for patient dignity. So I'd love to hear from you where where when we talk about dignity, where should this come from? Because obviously people have religious views. I'm happy to sort of state that I have a bias, right? I have my own Christian religious views around this, which won't convince anybody else, or not need be imposed on anybody else. But where does this mismatch in the understanding of dignity come from? Because clearly you're using the same word from pretty polar positions.
Yeah, no, it's such a good question. I just want to again highlight that again in suicide prevention efforts in modern healthcare, if you were to come into our hospital and say you were suicidal, and we, have all the suicide prevention and do everything we can with the suicide hotline, no one in those circumstances says, "Well, keep your
Yeah,
thoughts off my body." Like this is actually like, why have we fought against what we historically have always thought is a tragedy in healthcare against suicide? It doesn't come down to, in most situations, a religious argument in the secular world of suicide prevention hotlines, suicide prevention month, etc. I think I think it's maybe helpful to root this conversation in possibly a historical context about thinking about Hippocrates. Hippocrates, for many of your listeners know, was considered to be the father of modern day medicine. He was a Greek physician, lived around 400 BC. Um, and in his oath, the original oath, there is a prohibition. It says, I will go into people's homes for the benefit of the sick. And he didn't leave that up to our imagination. He gave very clear prohibitions as to what he thought physicians should not engage with to preserve the integrity of the healing profession. And so in that oath, it says, like, I will not give a woman a pessary to cause an abortion, and I will not give anyone a medication to aim at their death, even if, like, I would never even suggest it. Hippocrates was not a Christian person. He obviously, at the beginning of the oath, there is some divine accountability that he believes physicians have because the oath is taken under the oath of goddess and goddesses. So the question is, like, why did Hippocrates put a prohibition on killing in medicine? And it's because he knew that even with the revelation that he had, that probably one of the most important things that this would do if killing were introduced into medicine actually would destroy public trust. So, at the time, there were people that, were people who were in sort of this healing space, and you weren't sure actually when you engaged with them if they had your best interests in mind. And so to try to set medicine apart as a as a vocation of integrity, Hippocrates knew that if patients came to you and they weren't sure actually if you were going to aim towards their healing or if you were going to suggest that they be killed, trust could not develop in that circumstance. So I think that's the first thing that when I think about this topic is the integrity or the dignity of the profession would be corrupted if we distort the tools of medicine that have always used for healing and use them towards killing. I do recognize that words mean many different things to many different people. And so, specifically around the term dignity in this conversation, I think it's worth unpacking. So, I have an interest in something called narrative medicine, which is how do we think about language and stories in patient care, research, and education? And words, oftentimes, have a distinct history and rootedness, sometimes in moral communities or religious communities, but they sometimes can be co-opted in many different ways. And I do see placards oftentimes for the group Compassion and Choices, which is the main group here, especially in the United States. It used to be called the Hemlock Society, that advocates for physician assisted suicide. And they call physician assisted killing, as my friend Charles Tomosi calls it, death with dignity. And trying to unpack what that means, from a justice angle, I can think of nothing more undignified than me as a physician committed to healing, aiming directly at the death of a member of Homo sapiens, one that is made vulnerable, actually, by illness, advanced age, disability, as dignified. So again, we can say whatever we want, and people have the right to say whatever we want. But if we think about actually what the act entails, you are aiming at the death of a patient, a person that's entrusted to your care in medicine as a healing profession, and aiming towards their death. And they're made vulnerable again by their situation. That is patient abandonment. That is like as undignified as something that I could think of. So again, I just don't think that that language is authentic. I know people are using it in a way that they think is authentic for them, but again, from a justice angle, from an equity angle, from a vulnerable population, from a disability lens angle, not even put the religion aside, that is an undignified practice for a medicine person. I was at lunch today talking about this issue actually with a psychiatrist who, as a mental health professional, she's very worried actually about the expanding indication of medical aid in 9, as they call it in Canada, for people with mental illness starting in 2027. She's terrified about it. But she was talking about how this is one of those things that if we don't start being clear about our terms about this and let others define them for us in healthcare, that we're not going to be able to stay true to the
Uh-huh.
profession as it
Uh-huh.
is. And maybe in a pluralistic society, it would still be wrong. Take this act out of medicine. Do not co-opt medicine into this, because once we do that, again, the trust can't be built, patient physician relationships will be broken down, and I think it will just continue to undermine medicine as a healing profession if we introduce
Uh-huh.
legalized killing as part
Uh-huh.
of our toolbox.
Uh-huh.
So yes, I think the term dignity is a loaded term. I think some people think it's a religious term, but even from a justice angle, what is actually happening in this act, I would say, is undignified, because this is a patient made vulnerable by illness. And oftentimes this is an unchoice for these people. They feel like they're burdened. They don't have the necessary resources to be able to live in the way they want to. And they think this is like their only hope. And the last thing I'll say about this is, thank goodness actually for, I don't know what it's like in your part of the world, but in the United States, thank goodness for the disability rights community, who is one of the most vocal advocates against physician assisted suicide here, because they know actually that this can be framed all you want as like a choice to die, but eventually they know actually the choice to die will become the duty to die. And then
Uh-huh.
how undignified is that for someone, again, who already feels like a burden in the system, to really have no option left but to choose medical aid in dying? So for all those reasons, I don't think the word dignity here, when we think about it, what it means really makes sense when applied to the act as we know it to be.
Yeah, thank you. And so I did have a quick look. I mentioned the American Medical Association, but I looked up the
Hmm.
Australian Medical Association just out of interest, whether they
Oh,
have,
yeah.
because it's
Interesting.
not a topic that I really know much about. I probably also should have said that in the introduction, but they have a position statement that they published in 2025, but it's not a position at all. It basically says we stand with those who choose to and those who choose not to, um, which
Interesting.
I think is really, it's like, well, this is not a statement. It's just basically
That's an
saying
unstatement.
it's
That's
an
right.
unstatement. And so they've just sort of sidestepped the whole conversation, which is part of the problem, I guess. So I like that idea in a sense that maybe this could be more productive. Like you can remove a lot of risk or something like that by just moving this conversation outside of the field of medicine, put it somewhere else. And that kind of gets rid of 20% of the sort of like some of the risks involved.
Well,
Um,
yeah, again, just to say on that, I still want to be clear. I still think in a just society, we should not be aiming directly at the death of any member of Homo
sure.
sapiens. I still think it's an unjust practice, but at
Sure.
least, again, not to be crude, but it is not hard actually to end someone's life. We do not need medicine to be part of this. I once heard someone say, I give a talk in Canada about once a year on this and various topics, and someone once said, well, what if instead of physicians doing this, what if, if you wanted medical aid in dying, as they call it in Canada, you were to come to the funeral home, you were to like lay in the casket, you would get your IV,
Sure.
and the death technician or the funeral home director would come in and give you, and people were like, "Oh, that sounds really gross." But actually, like, like, that's what it is.
Uh,
If you put all of a sudden the white coat of medicine on this veneer of like legitimacy or cleanliness or um, licitness, it actually it seems different actually when a death technician does it, but it shouldn't, because it's the same. But we think there's this aura of legitimacy when we put it under the toolbox of medicine. But
uh-huh.
death is not a treatment. Death cannot be trialed. It can't be like reversed if we think this is the wrong thing, right? You're assuming, I guess, actually too, that like that whatever happens after death is like better than what's happening now, which means it's experimental, right? In all the ways we think about treatment and informed consent around a treatment, death actually cannot be a treatment. But
Hmm.
if, again, if in a pluralistic society, if the people vote that this is something that they want, I think at the very least, like, do not corrupt medicine with this act and actually move it out. But I still want to be clear, even in that situation, I think those of us that care about human justice and the inherent dignity of the human person should still think that that's still not okay.
Hmm. Hmm. Yeah, no, thank you. And I guess yeah, that's the sort of the risk I was talking about, is the risk of
Hmm.
the risk on the medical profession. So
Mm,
I can imagine there'd be people sitting listening to this going like, okay, within the narrow bounds of somebody who has zero quality of life, like let's just say they're on, like life support or something like that, like no quality of life, unresponsive. I
hmm
There'd be people sitting watching going, no, no, assisted dying makes sense in that situation, or that,
hmm
suffering
hmm
is so unbearable. I've had to sit and watch, a loved one go through this, and I just thought that made
Right.
no sense. It's so cruel that we couldn't
Yeah.
put an end to this misery.
Mm-hmm.
Um,
hmm
I do think even in that group they would say, so we can talk about that group in particular, but then they'd go like, but I do understand that there's a difference between that experience and
Right.
basically any other non-terminal case.
hmm Yeah, no, I think this is important to talk about. I mean, I think, first of all, again, and I think it's important to, in conversations like this, where there are many very reasonable people uh, who are people of goodwill that have different thoughts about this, try to find some common ground. And I think the common ground that all of us have in these conversations is that, like, no one is fighting for the status quo here. Like, no one thinks that we die well,
Okay.
actually. Again, I'll just speak for my context here in the United States. Like, no one thinks we die here in the United States, right? Death is like over medicalized. People with like incurable things at like 102 shouldn't be dying on the ventilator on ECMO, right? We have failed those people. And, you know, there are ways to like compassionately respond to the crisis that we're in about how we die in this country. And the question that of course is raised is like, what does a compassionate response to suffering look like? And then what I've heard, interestingly, which I think is right, from a Catholic writer, Leila Bresco Sargent, she said, when there is an error in the culture, and especially she thinks, when Christians speak out against these, and we say like no to euthanasia, right? We're saying no to physician-assisted suicide. She's like, they hear our no, but they're not really sure what we're saying yes to. But like,
Yeah.
no one's really fighting for the status quo. And I do think when we think about the example that you gave, let's say someone who clearly has an incurable illness, who is really within a few weeks of their natural death, exhibiting symptoms and signs of significant physical, mental, social, spiritual suffering. What is our response in that situation? So I think I want to be clear about a couple things. First of all, you could err on the side, I think, in these conversations of like, which I want to make sure people know I'm not advocating for, prolonging life at all costs. Prolonging life at all costs. I mean, that makes life into an idol. Like, we don't want to make life
Hmm.
into an idol. It's not. But we also don't want to be um, sort of discard life in a way that doesn't treat it with the respect that it should have. There are certain situations, absolutely an end of life, where we are making a choice of how to live, but we're not aiming at death. So, for example, you have somebody who has end stage lung disease, they're in respiratory failure, they're either going to need ventilatory support to be able to continue to breathe, but knowing they would never probably come off the ventilator, versus choosing not to opt on the ventilator, understanding that they would die. In that situation, the family and any good physician is going to be talking with that family and the patient about risks and benefits. And if they choose not to go on the ventilator, that is not the same as what we're talking about today.
Hmm.
That is actually making a choice, actually, of how to live. They do not want to live their last days out on a ventilator with no hope of recovery. So they would opt out of the ventilator. That is making a choice of how to live. And with the sort of principle of double effect, they sort of see right? They foresee that their death is coming, but they're not aiming at it. They're not aiming to die. They're actually aiming to live in a certain way without the ventilator, without ECMO,
Hmm.
without more invasive chemotherapy that's not going to give them any benefit. That is not what we're talking about. In those situations, you know that it's not physician assisted suicide. You know you're not aiming at death, because the check on yourself in those situations is, if that person, by some miracle, actually, if you don't offer them a ventilator, actually lives, you're thrilled, because you weren't aiming at their death. You were actually making a choice to like not take on more burdensome medical therapies, or you're
Yeah.
withdrawing medical therapies because you're making a choice of how to live. That's actually different. That's not aiming at someone's death. When we aim at death, you're actually giving someone a medication or doing something because you want their life to end. So at end of life ethics, we have to be careful about what we're aiming towards. And I agree, like it's perfectly reasonable in someone who is going to not have recovery that we think is meaningful after shared decision making, that they don't want any further burdensome medical interventions. That is not the same thing as killing or aiming at the death of your loved one. So I just want to be really clear about that. The second thing I want to say about that is that when we think about physician assisted suicide and the expanding scope of this practice, that's actually not the majority of people actually that are like choosing to die by medical aid and dying. I think whenever there's a group again here, Compassion and Choices, I've been to some of their talks, and oftentimes the way that they present their case is they usually do start, the presenter usually starts with some story of someone they know with some really, really hard disease, and talked about this suffering that does happen, absolutely end of life. And then therefore say, well, isn't that then a case for why we should allow physician assisted suicide? And again, we need to talk about how to support these folks for
Hmm.
sure. And we need better palliative care and better end of life care and better hospice support, better care support. But actually, if you look at data, actually, again, in the US, I don't know what it's like in other parts of the world as much, but in Oregon, where we've had physician assisted suicide for decades, um, intractable physical pain and suffering don't even make like the top three reasons actually as to why people request physician assisted suicide in Oregon. It's actually like fear of being a burden. It's actually
Yeah.
like loss of autonomy. It's actually like, fear of future pain and suffering. So these are still existential suffering domains that, again, we need to treat, but it's not the person usually that has intractable pain and nausea and these physical symptoms. Those people absolutely do exist, and we need better treatments for people at end of life and better accompaniment. But when I think about what a compassionate response to suffering look like, I think the biggest error that we could fall into would to say, in our attempts to eliminate suffering, we eliminate the sufferer. That is an impoverished model of healthcare and not healthcare at all. In no situation as a physician, if you were to come to me and say, I have symptom X, Y, and Z, and my treatment for you were to be like, well, we are going to get rid of you. I mean, it doesn't make any sense. Compassion means to suffer with. We need to be able to accompany people end of life, realizing that there is suffering that we do not do a good deal of, we don't do a great job of addressing, and do a better job of that. But what I fear happening is, because physician assisted suicide is a choice that forecloses all other choices because it's not reversible, it also is starting to foreclose other choice in those domains. So you've probably seen that in places where physician assisted suicide is legal, that hospice services are being cut, that funding for palliative care programs, because those things are expensive. And guess what? It's cheaper for you just not to be here. So then when I hear about choice at end of life, yes, I am for choices, but not all choices are created equal. And some choices end up foreclosing other choices.
Yeah.
And I've heard too, some of my colleagues at Michigan Medicine, they are researchers of diseases that we need better treatments for, ALS, myeloma, these other things. And they fear, and the patients who have these diseases fear, that if it's just assumed that as soon as you're diagnosed, let's say with ALS, that you have physician assisted suicide, guess what? No one will be researching that disease anymore. And the patients who actually don't want to choose physician assisted suicide will have like less options
Hmm.
for them possibly
Hmm.
in decades to come, because it's just assumed that once you get that diagnosis, you die. And then so there'll be no more advanced research on these issues. The last thing I'll say about that, because I think you mentioned choice at end of life, is that in states where physician assisted suicide is legal and someone lives in that state who has, let's say, an incurable illness or some type of disability that sometimes people assume that they should use physician assisted suicide, they have to defend their life against that choice. Where if that choice wasn't even on the table, they wouldn't have to defend their life again. So it's sort of subtly,
Uh-huh.
you hear from these patients, like it's always sort of in the room, like that subtle feeling like, don't you know, this could all be all over. And they, again, already feel weakened by the fight to sort of exist as someone with a serious illness, to sort of fight against that that assumption that they would be better off dead, again, that's a burden then you put on the sick person in some
Uh-huh.
of these situations. So
Uh-huh.
again, we think about choice. I think people think, isn't more choice better, actually? But like, there are choices actually that shape the way we see the dignity of people. They foreclose other choices for other people. And these choices, especially around euthanasia and physician assisted suicide, shape the way that we see the value of certain life over other people. And as someone who cares deeply about anthropology, dignity, and how we think about the view of the human person in society, that to me is a very under talked about thing. But it basically starts to shape who we think has value and who we think does not, and which lives basically as society we're like, yeah, actually it's better that those people actually don't even exist.
Uh-huh. Yeah. Again, thank you. This strikes me as extremely balanced. I don't know what people will be thinking as they listen to this. I hope that I'm not letting you off easy here because we probably agree.
Don't
But
let me off easy. Don't let me
yeah,
off
no,
easy.
no, that's okay. Um, what was I going to say? You can imagine this thing of like hospital beds are full, resources are minimal. How selfish that you're just choosing to basically to be here. You can imagine that very slippery, like that change in perspective. It's kind of insidious that you would go like, do you get what I'm trying to say?
Tell me more.
This
What
this
what do you
perspective.
mean?
Sorry, I know I'm not doing a very good job here. This idea that you go like, you've got no chance of this thing helping you, but you're trying and you're using up valuable human
Mm.
hospital resources. um you're making the selfish choice would almost become could become the perspective of somebody choosing not to die.
Oh, I see. Right. Right. No, yeah, I think, the conversations around healthcare resources are a very important one. And I do think that whenever we talk about topics like this, as a realist, also, we do need to think about financial aspects of this conversation.
Uh-huh.
And again, I want to be clear that most of the cases that we're talking about are not in situations of limited healthcare resources where we're running out of ventilators, right? And like there are these people that are like selfish, right? That hanging on. Like actually that's not really, I think, the conversation that we should be able to talk about liminal cases and extreme cases, but
Uh-huh.
they don't really make up the majority of the concern around this topic. But I do think it's thinking about resources and healthcare resources, which are limited. I do think financial incentives and the way that finances intersect with this conversation, I think, is really important. So there was a case actually here in the US that was in California. And there is a mother there. Her name is Stephanie Packer. She's a woman that has some type of mixed connective tissue disease, and she lives in a state, California, where medical aid and dying, as they call it, there is legal. And Stephanie has children, she's married, has a nice support system, but has this chronic illness. And so Stephanie has lung disease is related to her mixed connective tissue disease. And she went to her doctor who recommended a prescription to help her with her lung disease. And she took it to her pharmacy in California. And she was told that her insurance wouldn't cover the medication. And so she asked out of curiosity, she said, if I instead had had a prescription in my hand for pills to end my life through physician assisted suicide, how much would that be? And she was told that the copay for that medication would be $1.20. She had enough fortitude and social support and wherewithal to be able to say no to that choice. But again, I think when we think about how expensive it is to take care of people who have chronic illness, and how I would say in a just society, side of rich resources, we should be able to take care of people with chronic illness, that the disabled community is very worried that, boy, they already feel like sometimes they're made to feel like a burden in society. And that all of a sudden, if the forces of the market
Uh-huh.
get into this conversation, that like it becomes an unchoice. Like you could choose to sort of live, but this is going to be really expensive for you. And insurance isn't really going to cover your medication. But look at this. You can pay $1.20 and like make it all go away. So I think when I think of the selfishness and I think of the bad actors. It's not the patients that are being selfish, asking to just live their lives and have their, illnesses treated. But I'm really worried about the forces of the market and the forces of the state actually
Hmm.
making this an unchoice for people. There was
Hmm.
actually really interesting thinking about money. I read recently that the Canadian government actually just gave the Canadian Psychiatric Association around $500,000 to develop some clinical guidelines around psychiatric euthanasia. And again, like anytime you have money flowing from one party to another, there's already this incentive, right, to make these guidelines allowed. There also was really interesting data. It was written in the British Medical Journal in Oregon. Here, again, we have a lot of data from that state. When physician assisted suicide first became legal in Oregon, up to like 65% of those seeking that treatment there in Oregon were privately insured. And by 2021, about 80% of the people who chose to have physician assisted suicide in that state actually were on government insurance. So, again, thinking about the populations who are most at risk for this, these
Hmm.
are patients that already are made vulnerable by all these circumstances. And the shifting of the choice to an unchoice because of financial incentives, pressures from the market, pressures from the state, pressures from loved ones. So I think if I want to think about who's being selfish here, this isn't like, the story like these folks are like fighting for like limited ventilators. That's not really not the situation we're in. These are just people who are asking to be treated humanely in a system that, yes, I grant is very broken. And let's think about making that system better. Let's
Yeah.
think about how we can rehabilitate, right, the healthcare spending that's spent on things that don't have benefit versus where it should be spent. Because my goodness, I think that conversation is the one we should be having instead.
Yeah. Yeah. Thank you. I've remember a book. I've got it at home somewhere, but it's about person-centered care in the context of
Hmm,
psychology. But they
hmm,
had this table that's always stuck with me, which was basically
hmm,
how do they do it in disability? How do we do it in psychology? And
hmm,
kind of the role of the physician, I guess, in that setting. And they talk about, well, what's
hmm,
the relationship between the physician to client or whatever you want to call
hmm,
these groups. And it's kind of like in psychology, it's very much about expert and, kind of patient, top down sort of
hmm,
thing.
hmm.
In disability, it's about side by side,
Right.
and the role the I guess the argument was like these are hard fought wins that the disability sector have built, and I'm wondering, this would almost be taking us in the other direction. As you said, I'm glad that you've reminded me of the disability sector and the value they've brought.
Hmm.
This idea that actually, who is advocating for the life once this option is live and sort of like accepted.
Yeah, no, I think that's really good. I was at a conference last week and I was talking to somebody who testified in one of the states in this country around, like he was testifying against physician assisted suicide. And he said the other side, the side that was trying to get this bill passed in a state, were people who seemed of immense privilege, or mostly, upper middle class people who had a lot of privilege and a lot of influence. And his side, the side that actually was trying to prevent physician assisted suicide from becoming legal in the state, he said it was just like a motley crew of folks, like people from the disability community, like minoritized persons, like, and they like felt very strongly that this would put them at risk.
Hmm.
And I think about, I do a lot of thinking about ableism in medicine and ageism because I take care of mostly older people. And we already know that medicine has a problem, shamefully, with ableism. So if you show, there was a study that, if you show a picture of a person with a disability to a physician, the physician will rate that person's quality of life lower each time than if you ask the person with a disability themselves. There actually was a study by Azzoni in Health Affairs a couple of years ago also that something like 70 some percent of US physicians believe that disabled people had like worse quality of life than non-disabled people. And
Hmm.
when physicians hold power over people's lives and have ableist views, then like people's lives directly will be at risk. There actually was a study done by Timmermans that looked at how people were resuscitated by physicians in emergency settings. And these are people who presented with out of hospital cardiac arrest. So the physicians, because these people were in extremis, there wasn't time to ask them, like, what do you do? Like, what kind of station do you have in life? They had to make actually value judgments based on the person's appearance as to whether or not they thought these people would live or die, because these people were not all resuscitated the same. And the people that were not resuscitated with like a standard of care, or people looked like had stigmata of disability, people who are of advanced age, people who looked like they maybe had stigmata of being addicted or having being undomiciled. And those people were not resuscitated the same way as other people. And there are all people for sure that are socially dead to all of us. But what the study showed actually is that your social death predicts your cardiopulmonary death at the hands of physicians. So again, in a system where disabled people already know that their lives are not valued in the same way as non-disabled people, they are very afraid, rightly so,
Mm.
actually, of this coming around. Because if you're never taking care of someone, and if a physician already feels like that person in the bed in front of them doesn't have the same quality of life, they're likely already to get maybe referred for MAID or to be offered that as a treatment. So, my goodness, I think the disability has a right to be worried about how this kind of rollout in a system that already doesn't value their lives based on the
Hmm.
data. They should be really worried. There was that study or that story, I don't know if you saw it, of a man, he had trisomy 21, Aidan Polton in the UK, a man with Down syndrome, broke his hip. He went into a place that he thought would help him, a hospital where doctors would have able to help him. He went in the hospital. He was made NPO, nothing by mouth, because they assumed he was going to have surgery for his broken hip. And the surgery never happened for some reason. But the NPO order was never lifted. So he stayed nothing by mouth actually for a week. And then he died actually of dehydration. How did that happen? It's because like no one questioned his NPO order. He wasn't able to advocate for himself because of his disability, and he died. Again, hard to know exactly what happened, but we know already because of the ableism within medicine, there are stories upon stories like that. There were stories during the pandemic of people with trisomy 21 just on the basis of their disability, not being offered ventilators. It's a civil rights violation here. So I think the disability community has a right to be concerned about this. And it's and again, when there's that power differential, I know you talk about top down and sort of expert. Still in hospitals, there is a power differential between
Yeah.
physicians and patients. They're already made vulnerable by being disoriented, being in this place. Physicians have power. We have to get that right. And introducing physician assisted suicide in a system that already doesn't value older people and disabled people the same is just a setup for like health inequities going forward. So in a lens of justice, it just doesn't. It's a very dangerous thing.
Hmm. Hmm. Yeah. Okay. Thank you again. Yeah. In terms of there it's quite an uncomfortable conversation, like to be having, because it's
It
I guess
is.
I'm non-confrontational by nature probably, and so even knowing that people will be listening to this vehemently disagreeing, I guess just gives me like
I
bad
know.
feelings. But
I
I've
know.
pretty got to be stronger than that. But I think people will, and people already have. I posted the screenshot of your tweet about coming on the
I
show,
saw.
and LinkedIn. Even on
I
LinkedIn,
saw.
people were like, they were
I saw.
disagreeing. I don't think that they were like super negative, but I think someone made like a distinction where they basically go like, no, this makes sense in the case of, assisted dying makes sense when there is suffering that is unrelenting.
Right.
Whereas if there's something we can do about it, then obviously, the life has value. I wonder if you can talk
Mm-hmm.
to, whether there's a clear line between this kind of transient suffering where,
Mm-hmm.
prevention makes sense versus
Mm-hmm.
unbearable suffering where it should be,
Mm-hmm.
where assisted dying should be
Mm-hmm.
offered.
Mm-hmm. Yeah, I just want to say that, as a physician and someone who's seen a lot of suffering, death, and dying, nobody knows actually when faced with a period of suffering what that period of suffering means, what awaits them through and at the end of that period of suffering, or what the future shape of their life looks like. And that's why, right, we forever have said, boy, if you come in and you're suicidal, end of life or not, that we have said that this isn't a good choice for you. And to sort of assume that, that we have, that we can play God, or that we assume what our future shape of our life looks like, to say that we're going to decide that you are better off dead in this moment, I think is a grave moral error. There are so many people who I've taken care of that I've seen this to be true, that I think the pro physician assisted suicide movement, particularly compassionate choices, I think is selling somewhat of a lie. I think the lie is this, that, a controlled death equals a good death, and
Hmm.
a messy, uncontrolled death equals a bad death. And actually, so many of the times, actually, that's just not the case. And there are certain scholars, I know you know this, Xavier Simmons in particular, who has written scholarly work that shows there are probably some goods actually that can only be achieved actually at end of life. Again, not to minimize the suffering,
Yep.
not to cherry coat it. There is absolutely suffering that happens at the end of life. Um, but to truncate our lives and to pretend that we know exactly what will happen through that period of suffering, um, I think is a degree of hubris that forecloses possibility. There's always something to hope for, actually, even at end of life. And it's one of those things that I think when I hear about people advocating for physician assisted suicide, it comes down to this autonomy argument. And again, as someone who thinks deeply about these issues, we know actually that, this is not a decision that ever happens in like a lead box. Absolutely. We think about, hopefully most of us, even within the framework of autonomy, also care about the common good. And we know actually that suicide is contagious. There has been work by like Yale's uh, Dr. Christakis who's shown that actually all behaviors, including suicide, are contagious. And everything that we do affect others up to 3 degrees of separation, like affect our friends, friends, friends. And suicide is no exception, actually. So sometimes some of this argument's made, well, if we allow for physician assisted suicide, we're going to do it in a controlled way and cut down on other suicides. And actually, there was a study in the European Review that showed actually that in places where physician assisted suicide was legal, all suicides went up because you are planting a seed that actually maybe it actually is appropriate for you no longer to be here,
Hmm.
but it's the wrong type of seed. So actually, if we care about the common good, this suicide, whether it be licit or illicit, right, causes all suicides to go up. And actually, if we care about health equity, there was interesting data out of the Netherlands, which I think can be extrapolated given what we know about suicide, is that women in particular in the Netherlands try to die by suicide at like twice the rate of men. But they really don't succeed most of the time because they choose oftentimes less violent means than men do. But then, if they have access now through physician assisted suicide, then those women are able to complete suicide. So actually, you're
Hmm.
allowing actually more women and girls actually to complete and die by suicide through legalization. And it just doesn't also impact the person themselves. There was such a good piece, actually. It's about 10 years old now. It was written by in the US by Rachel Aviv in the New Yorker. It's called The Death Treatment. And it tells the story about Godelieve de Troyer, who was a woman in the Netherlands, I believe, who had very bad depression. And she ended up dying by suicide. And her son in the story found out about it after she had died. He basically got notification that his mom had died by euthanasia. And the story outlined his grief and lament and anger at a healthcare system that allowed this decision to happen without notifying the family. And
Hmm.
he, which I think makes sense, was like, her suicidal ideation was a symptom of her undertreated depression. That should have been like treated as such, as a symptom of her illness, not as this autonomous choice. And so when people say, well, just, unlike abortion or unlike these things, doesn't affect other people, it does affect other people. Total suicides go up. It plants the idea in society that some lives are not worth as much as other people. And it affects families and people and women and actually creates new victim classes. So one last thing I'll say about that when I think about, again, it just affects the one person, let people choose. It shapes who we see has value and who doesn't. There was a story in Canada where there was a Paralympian who was a wheelchair user. She went into the VA, you probably heard the story, and she asked for a ramp for her wheelchair to navigate her home. And she said that the VA sent her a communication that said, well, have you considered medical aid in dying? And she was like, no, she's like, I just want a wheelchair ramp right from my home. But once we say, well, this group of people with disabilities, or if you have ALS or you have paraplegia, those are the folks that actually we say through the law that you're better off probably if you're dead and you're allowed to die. It shapes the way that we see these people. I once heard writer Susanna Black say something which I think is so true. She said, the law used to teach you something about yourself. It used to say that in some way you were too holy to harm. And it was wrong to kill yourself and it was wrong to kill somebody else. Now, all of a sudden, if we don't have that law, instead the law says, you know what? it's fine if you're not here, and actually might be preferred, then she said, not only will you be less likely to see that sacred nature in yourself, but you'll be less likely to see it in other people because people are at least, somewhat affected by what the authorities tell them. So when we legalize this and make it seem like, well, if it's legal, it must be good, it shapes the way we see certain populations. And
Hmm.
the last thing I'll say about this is when I think about, you gave the example, what about the people that and again, prognosis is a very poor science in medicine. And you think, well, if they have 2 weeks, actually, doctors are terrible. Actually, there's so much data we don't actually know how long people have to live. So that's a false prophecy there, actually. But let's say you're like, well, can we just allow it for the people who we know for sure, right, have 2 weeks left to live? Once you open the door to that way of thinking, there is no coherent moral container that you can put around it. Because then I could raise my hand. Let's say I'm a 45-year-old woman, and let's say, I have a chronic pain syndrome and there's no good cure or therapy for me inside. I could say, wait a minute, why does that person who has maybe 2 weeks left to live, why do they have more self-determination over their autonomy? I might have 40 years left to live as someone with chronic pain. Why don't I have it? And as soon as we say that suffering is a vehicle through which the state or the profession can help you end your life, there's no way you can contain it. Because who's going to adjudicate that your suffering that you might have for 30 years is less valid of a reason for medical aid
Hmm.
and dying than someone who has 2 weeks to live. And that's
Hmm.
exactly what we're seeing in Canada,
Hmm.
right? Mental illness, not even foreseen within the next 2 weeks, children, anorexia, a lot of young people in Canada think actually medical aid dying is an appropriate response to poverty. It becomes this all consuming way to fix people's
Hmm.
problems. And
Hmm.
actually, it's an abandonment of people we actually should be coming around.
Thank you. Yeah, and it does feel insidious. I think I saw a paper that came out of Canada, and maybe it just seems to be crazy what's going on there. But I saw a paper that was like people don't actually understand. They assume that the law is reasonable. Like what have we allowed
Mm-hmm.
here? It seems reasonable. Once they actually have explained what is actually allowable within the law, they disagree with it. And I think there's this really terrible term. It's like it was something like consenting minor or something like that.
Right.
I forget
Right.
exactly what the term is like. Yeah, basically something along those lines. It's like just the broadest terminology that really is quite anyway, it makes me uncomfortable. I wonder, in this idea of absolute sort of because this is a moral question, and this is where I think we've talked a lot about on this podcast of where is the line, I guess, of sort of science, this issue of scientism, we don't know it until an RCT comes out and tells us it's true.
Mm.
Um, this is not something that science can answer for us. We seem terrible at dealing with moral truths as a society these days. And you mentioned the paper that came out talking about the risk that suicides go up as legislation around assisted dying comes up. I saw people then going, well, look at this author. This guy is from I think he's from Oxford, the Ethics Center, but he's you know clearly influenced by his religious beliefs. We don't seem to have this way of having productive conversations, particularly when it comes to things of morality. So I wonder whether you could speak to, if it's relevant, sort of this absolute morality versus kind of relativistic morality, this idea that, human life have value and worth, full stop, would be an absolute moral term. Whereas once we start saying, actually, they have worth, except in these conditions, how that kind of creates a slippery slope, or have I missed the kind of framing of it?
That's good. That's good. So at this lunch I was at earlier today, I was talking about, I was coming on your show and talking about this, and one of my colleagues at the table was a surgeon who had done palliative care training and does not believe that physician assisted suicide fits any coherent model of healthcare in any way, and he thinks violates the physician's commitment to do no harm. He said he was on a panel actually with some folks talking about this topic a few years ago, and he was on the panel. There was a rabbi on the panel. There was a Unitarian minister on the panel, and some other folks, and they all had very different shades of gray of how they thought. He was very much against it. Someone was very pro, and a lot of people were sort of in the middle, like, I don't really agree with it, but who am I to say for someone else, Um, and then he said at the end of the panel, the moderator said something like, well, isn't it great that we live in a world where all of us can be right? And I absolutely almost like choked on my lunch. And I was like, no, 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 that didn't happen. He's like, no, it did. And so Dan, who's a philosopher, he was like, not in my universe. Like that doesn't even make any sense. We can't all be right about this topic. Like that doesn't even make any sense. So I do want to engage your question seriously and say that yes, I agree that people of religious faith come to this question from a particular vantage point. But like, guess what? So does everybody else. Everybody actually is coming to the table at this topic and every other topic with their own first principles, with their own faith claims, with their own sort of view of the good. Everyone
Hmm.
is claimed by some authority or intuition or body of knowledge or worldview. Religious people are not uniquely awkward in that way. So, if a Christian person comes to the table and says they have faith claims, they have faith in the resurrection of Jesus Christ, they have faith in God, guess what, everyone else has faith claims too. People have faith in science, they have faith in progress, they have faith in mankind, they have faith in politics. Everyone has faith claims. And when we come to the table in conversation, there's no reason to then, because everyone comes to the table with faith claims and first principles, then sort of uniquely decide to exclude religious people. That doesn't make any sense. And yes, like everyone comes from their thick commitments. Religious people are no exception to that. So there's no like view from nowhere. Everyone's coming from some kind of
Hmm.
worldview. And I have to say that, I think, just put my cards on the table too, as a Christian person, I have the view that physician assisted suicide violates the intrinsic dignity of the human person, and that every human person has inherent worth and viable dignity because they're made in God's image. If I'm bringing that to the table and are concerned about vulnerable populations and the introduction of killing into medicine, if that makes me an extremist, so be it. You know what I'm saying? I don't think that like having people argue that like people actually that life, is something that is precious and we should be good stewards of that. If that makes me an extremist, okay. But I think from a philosophical and logical standpoint, there's no coherent argument that you can have to exclude religious people from the table. Everyone's coming to the table with their view of the good.
Hmm.
And
Hmm.
then what I'll say about that, you said that, this is a moral issue. It is a moral issue. Uh, um, as I think, it's also a justice issue. It's also an economic issue. It's also an anthropological issue. And I think for us to have a conversation that makes sense about this, we should have people at the table actually from all these fields. And the people who really also should be at these tables in conversation should be the patients. So many times conversations are made and decisions are being made, and like the stakeholders that these decisions affect aren't even there.
Hmm.
So, of course, we need people. We need moms and dads of disabled kids at the table. We need people with chronic illness at the table. We need people with like advanced neuromuscular conditions at the table. How do we think about this? And, as you said, trying to find a place of like starting point of common ground. The common ground in this conversation is that like all of us have lament over suffering that we see, myself included. I have significant lament and grief over what I see and what we are not able to do for people who are suffering. My response to that is like, let's work on that. The impoverished response is like making those patients go away.
Hmm.
Um, so we all care about this topic. I would say we all care about, human beings. We care about suffering and the problem of suffering. I think most of us will say we care about the over medicalization of death in this country. And like, let's start there. I would say most of us care about vulnerable populations. Most of us care about, people, at the margins and health equity. Like, yes, we all care about that. We might have some different ideas of like what that looks like, but let's think about where we can build some consensus around this topic. But yes, I do think, every medical act, because it's a professional act, is not just a technical one, it is a moral one. So I like your point in the fact that the science alone it's not going to be able to answer this question for us, because science doesn't tell us like should we do
What
something? It
is
can
good?
tell us
Yeah.
like how it works or like, but it's not going to give us the like should or the, the underlying foundational girdle of the should we do this? What is the morality or the justice issues behind this? So that's why it's so important to make sure that we have a panoply of voices at the table so that this topic can be informed by a justice moral lens. But I appreciate that question.
Yeah, thank you. And have you seen many sort of efforts to, I don't even know what we'll call it, but like basically bringing together people who are, you seem to talk a lot, you've referenced a lot of panels and conversations and stuff. Are there, has there been success at getting to the bottom of, where we agree
Hmm.
and where we disagree and
Yeah.
what might be a more useful way forward? Because it seems that the sort of the policy world just keeps marching on, and the kind of like the bracket creep continues.
Yeah, no, I know. I think, there we can do better about having conversations from points of shared agreement and thinking about where to build from here. I do think one success that, again, it is in the policy realm, but I do think it was a success because of many invested stakeholders and invitations of voices at the table. Actually, when you referenced it, was actually the AMA's recommitment to a non-neutral stance about physician-assisted suicide. So the AMA has like delegates and obviously many stakeholders that were able to testify and bring forth concerns about this question of physician assisted suicide. And I think those of us that are, again, as I'm going to say, on the side of justice on this issue are very happy to see that they, again, had moral clarity around this issue because these statements do matter. They shape the way we think about licitness or illicitness of things within medicine. So for the fact that the AMA said physician assisted suicide is incompatible with the physician's role as healer, would be difficult or impossible to control. All this is true, and it pose serious societal risks. Like, thank goodness, thank
Hmm.
goodness. And that only came about because of conversations and advocacy by many people. And also in that statement, which I want to point out too, which I think is very helpful, then coming back to where we started thinking about language, they refused to change their language to medical aid in dying. They kept it as physician assisted suicide.
Yeah.
So much debate about this, so much, screaming, crying, throwing up, as I say, about these words. And there should be, because words matter. But they very coherently said that for those of us that work with people at end of life, medical aid in dying is just an unhelpful phrase. What does that even mean? We
Hmm.
help people along the dying process all the time. That's what palliative care is, right? We're helping patients as they are dying with symptom management and nausea and spiritual care and pastoral support and reconciling families and all of Cicely Saunders' model of total pain, physical, social, emotional, spiritual pain. All of that is being aided and helped as they die. That is categorically different than aiming at someone's death. So thankfully, not only did they affirm a stance that actually means something, but also refuse to fall into the nomenclature
Yeah.
game. And they
Yeah.
kept it as physician assisted suicide.
Interesting. There we are. Thank you very much. I wonder, just to finish us off, like in
Hmm.
terms of, you know, the strongest argument for, I wonder what you think the strongest argument for, I'll keep saying assisted dying,
Sure.
because I said I'm weak, but what's the strongest argument if it's autonomy and, dignity? Like in two sentences, why do you disagree?
That's such a good question because oftentimes I'll be stuck in an elevator with someone or on an airplane or in line at TSA. And I was like, and people are like, where are you going? I'm like, I'm going to give this talk on physician assisted suicide. And they're like, what are your thoughts on that? So I'm like, what is the one thing that I want to say that I think is most helpful? I actually think the thing that every time I bring it up and people are like, oh, yeah, that doesn't really make sense. It's actually like, help me understand why we have suicide hotlines and suicide prevention. But in this other situation, we say actually suicide's okay and that we're going to have a physician help you do it. Can you help me understand why that's the case? And people are like, oh, yeah, that doesn't really make sense. Like, do we think suicide is a tragedy or not? And they're like, well, that's really interesting. And actually, the data, like Alexander Rakin, who's written about this topic for the New Atlantis and such, the data from Canada shows actually that people can't tell the difference. If you call a suicide hotline, it'd be incoherent for you to call a suicide hotline and be like, hi, I'm suicidal, for them to say, well, have you considered suicide? Like, it doesn't make it make sense. It doesn't make sense. And actually, Canada is having trouble actually telling the difference. Um, so yeah, I think it's the suicide prevention because everybody's familiar with the suicide hotlines, National Suicide
Uh-huh.
Hotline, Suicide Month, National Suicide Prevention. And this other situation, we're saying actually it's okay, and people are like, "Well, yeah, that is really hard for me to reconcile." So I think that's probably the talking point that sticks with most people. And I just want to say too that in my travels talking about this, because we talked about suffering and whose suffering is worthwhile and whose isn't, and how that is hard to adjudicate, sort of in these conversations. Um, so many people, young people that I've talked to that said, boy, 10 years ago, they said, I was suicidal. These patients tell me I got a new diagnosis or something. And they're like, if medical aid and dying, in Canada where they live had been legal, they're like, I wouldn't be here right now. And they're like, but my situation changed. I'm like, so thankful actually that I'm still alive. So thinking about how suffering isn't like a fixed thing.
Hmm.
The last thing I'll say about this too, just because I think, crossed my mind when you talked about the AMA and sort of legitimacy of practice. Again, if this was such a legitimate upstanding practice that we were so proud of in the countries that have made this legal. It's interesting, like if you die in Canada by medical aid and dying, the death certificate actually can't list MAID. Why is that? If we're
Yeah.
so thinking that this is such a legit thing and we're so proud of our ability to sort of take our patients' lives in this way, it's not allowed. You actually have to list, you can't list MAID as a cause of death or the meds administered. You actually have to list the underlying diagnosis that led someone to seek MAID. But like, why is there that like bureaucratic like switcheroo? Right. So again, for something that should be like very like legitimate out in the open, like make it out in the open, friends. Like,
Uh-huh.
why is
Uh-huh.
that the case? So
Uh-huh.
again, I just think if we think about even not from a religious lens, but from a human justice lens, this is definitely something that I would say if we think about it together is a violation of intrinsic human dignity. And at the same time, we need to do better to accompany patients with chronic illness at end of life, better caregiver support, better hospice palliative care, research, accompaniment, etc. Because no one is fighting for the status quo. I think that's all something that we can agree upon.
Yeah. Yeah. Thank you. Yeah. That's that side of it. I do think that is, I couldn't believe that when I came across that because it just makes, I think it makes it so hard to do any analysis to say, well, what's actually going on here?
I
And,
know.
and I did see, I don't know, maybe you know the stats of, I think it was like 5% of deaths in Canada are MAID.
That's right. That's right. I
5,
mean, when
you know,
I tell people that stat, they absolutely lose their mind in the United States. I'm like, like about 1 in 20 deaths is now related to medical aid and dying. And I mean, literally a picture of the slippery slope
yeah.
of how that looks there, because that is an immense amount of people who have died at the hands of medicine. And that's really an abdication of the patient, an abandonment of the patient, and really not something at all that we should find coherent with the healing
Hmm.
profession of
Hmm.
medicine
Hmm.
whatsoever. No, it's that number is exactly right.
Yeah. So listen, Kristen, thank you so much for being here.
Sure, Matt.
I've learned a lot. I hope that people have seen this as a balanced conversation. I don't think it's a voice that people hear very often, so I'm really keen to hear what people think. And I think the one thing that I'll come away with is this tendency we have to draw these lines, these sort of war lines of I'm on this side, you're on that side. But really those lines are around solutions. So
Hmm.
we kind of agree on the problem, like you've said, we agree, like we can agree that actually the way we over medicalize death, the way that we don't have, dignity in or autonomy in the process of dying, we can agree on that problem. We disagree on the solution.
That's
And
right.
for some reason, we jump straight to the solution mode. We draw our lines and never solve anything. So I
Right.
wonder whether, getting back to this, what do we agree with? What do we agree on? What are the problems, and maybe we can advocate for better solutions.
Yeah, there's so much work to do and are seriously ill and disabled and vulnerable patients, not just in the United States, but across the world. They deserve better. So hopefully we can work towards that as a just society.
All right. Well, thank you very much for your time.
Thanks, Matt. Thank you.